Welcome, Professor Kücükkeles from Turkey. You are a member of the editorial board of European Journal of Clinical Orthodontics. You are a professor, so you are also an academic person. What is the importance of publishing for a person in the academia, but most importantly for a private orthodontist?
Well, academicians are supposed to publish. I mean, they're supposed to be doing it because that's the reason they're at the university, and that they usually the country's bylaw and the rules of the academics are leading them to do so. Even though some of them are more energetic, more actively working, some don't publish much, but still they keep publishing somehow. But coming to the dental practitioners, I think it would be really good work. It would help them a lot to scan their work. It's not easy to carry out a research if you're not connected to a university, but at least they can write case reports. They can go back and check their challenging cases or the cases that are not so challenging, but it turned out to be very nice cases. They can scan their cases, they can get their records, check the records, and then they will find out very important tricks when they are writing their case report, because they will refer to other articles and they will also find out what other people does in the same situation. So we can learn from our mistakes and from our positive work.
Maybe out there are dental practitioners who are experimenting new modalities, new treatment modalities. You as a professor, you presented here in Riga a lecture about new treatment modalities for the correction of class 3 in growing patients. Would you like to tell us something about this?
Yeah, actually I've been lecturing about this topic since a few years because I'm having the results of the studies. About maybe 7 or 8 years ago, we decided to create a treatment protocol for the class 3 malocclusion with a very critical age, like 12, 13. Why critical? The orthodontists will know that before the age of 10, normal face mask protraction or other treatment protocols are responding well. I mean, the results are nice because the sutures of the patients are not rigid, so you can pull maxilla forward and achieve a nice facial change. But once the patient is 12 or 13, since the sutural rigidity increases and we don't expect much correction on the mid-face, so what we try to do is actually a camouflage of the skeletal problem. We can correct it anytime, but it doesn't mean that it will appear nice on the face. And what we try to do is to prepare a protocol with surgery assistance. Before face mask application, our patients underwent a surgical protocol, which is named as Leport 1 protocol, which releases maxilla from the cranium. The operation was made under general anesthesia by surgeons, and then they start wearing the face mask about 3-4 days afterwards, and this is called this distraction protocol. What we achieve is about in 2-3 months, the face totally changed because the upper jaw, upper lip, and the mid-face, even the nose, lift up, and the middle face come forward, so their face totally changed to a normal orthodontic profile. And since it happens in 1-2 months, it's very motivating for the patient. They like the results, so they are very much motivated to wear whatever you give them to. And then after this study, we had for sure some problems during study, and then we designed another protocol, which is an intraoral protocol, still using the same advantage of the corticotomy, but this time the mechanic was inside the mouth, the elastics between the lower implants in the lower anterior region and in the upper acrylic splint. But still we cut maxilla, corticotomy was performed on the maxilla, and the maxilla was pulled forward in 2 months or so, because intraoral elastics are easy to wear. They're more cooperative with the elastics. And I believe that this mechanic worked even better. Why do I say that? Because for the first study we had about 6 years long-term results, and we published the short and long-term results. If people are interested, it's free of charge. I mean, online access is possible to the I'm not calling the name of the journal, but the Angular Orthodontist, published in the Angular Orthodontist, and they're both free online. And about the new method, the last method we applied, the intro protocol, is something similar to Hugo Clark's method, but there they are trying to get the advantage of the sutural activation. The sutures should be active. So there you're limited with the age. If you're applying implants in the lower anterior and upper posterior region using elastics in between, okay, that's good. If the patient wears it, you will have a nice result, protraction of maxilla. But then, if the patient's sutural rigidity is increasing, if the patient's in post-peak, then you can't expect much. Even the anchorage is bone, no problem. You need a young age, I mean before the age of 10. We know this from the studies. And then with the in this age, then you need something faster, or you have to tell your patient, wait 7 years and then come for surgery, which is not fair because their faces don't look nice and these kids are really unhappy. And then what we do is this technique with the elastics, the corticotomy, 2 months, everything changed. And then in 5 months we have very dramatic results, and then we demold the device and we continue with normal mechanics. And you know, well, some people ask me, why don't you just operate them, you know, bring the maxilla forward? It's not the same. This is a distraction protocol, and with the with this protocol, the patient's osteotomy site is filled with the original bone of the patient itself, and you don't interfere with the remaining growth afterwards. The growth and development continues normally, and as we see, now we have the 4 years results, and we superimposed the cephs, and we found out that the growth is very favorable. The mandible rotates forward, maxilla moves forward, they still grow very nicely.
So it's not only a surgery,
it is a surgery, it is a left 1 surgery, but we call it
less
incomplete.
Than,
less invasive because, first of all, they perform the osteotomy through left 1 line, but they don't down fracture maxilla. They just release maxilla from the cranium, and it is mobilized during surgery, not too much, slightly mobilized. And then what happens is they don't have rigid fixation plates. The growth and development continues normally, and many advantages. They're not hospitalized. They usually come home the same day. They pay a lot less, for sure, compared to the other radical surgery.
What is the ideal age for this kind of intervention?
Well, if patient come to me before the age of 10 or 11, I would check for the growth and development on the hand wrist or the cervical vertebra to make sure that they're in the peak. If they are over peak, I wouldn't go for normal orthopedic traction methods. I would go with this. So over 11, in 12, in a severe case. If it's a light case, maybe I would still use some face mask and camouflage if the soft tissue profile is acceptable and the patient does not demand for facial change. But if there is a radical concave profile and the patient is expecting change, and even the patient is not expecting change, I wouldn't like to give her a camouflage because I know it's going to relapse. But there are so many publications about it. We know that dentoalveolar changes relapse. It's not something new. So why not to bring upper jaw forward radically and having less camouflage but more orthopedic result. It's nice on the face as well. So after 11 or 12, I would be very accurate. I will try to accurately estimate the age, the growth age, if the patient is still in peak. If not peak but post-peak, I would go for surgery-assisted protraction. Simple, cheap, and very effective.
And improves the compliance of the patient at that age.
Yeah, because I show the pictures of the former patients and I show the date of the pictures. They can see what happens to the faces in 1 month. It's totally a different person. I mean, very positive. Yeah,
nice.
Yeah, very positive.
I have a question about Riga and about Baltic countries, because it is quite interesting to see how much involvement the Baltic countries and Northern European countries and Eastern European countries are getting involved into this discipline, which in some ways connects to architecture, if I may say.
Yeah.
because it rebuilds the architecture of the head, actually, from a functional point of view, of course. Why do you think there is so much interest from European, Eastern European and Northern European countries?
Well, actually, I have been traveling to this area of the country, of the world. I'm sorry, since maybe 8 years. I'm coming to Russia so frequently every year, and I have been to Estonia several times for making courses. So I can see these people are so eager to learn new things. And this Congress particularly is a very nice one, very well organized. First of all, there are many things for surgeons and many things for orthodontists, and these two professions should be working together to have the most harmonized faces. So I think collecting them together is a great idea, very nice idea, and that's why they probably, it's about 800 people.
Yes.
We're very close to what we achieve in some European Orthodontic Society congresses. This area is also, the people, well, mostly women though, but you know, what I see is in many countries, this profession, orthodontic profession, is mostly women, but they're very eager to learn and they are very eager to share. And the names are selected so nicely, very nice people, very nice lecturers out there. So it's a very nice congress, well organized, perfectly well.
You were part of it, so you added value to this congress.
Oh yeah, that's nice. Thank you for hearing it. But I'm talking about the other speakers as well. I met some people that I didn't listen before, but I've heard about them. So it was also a very nice opportunity for me.
Thank you very much.
Thank you.
Would you like to say
Thank you for inviting us. Thank you for inviting. Make more publications, dear practitioners. It's going to help you to improve.
Maybe in correspondence, in conjunction with the people from university who see so many cases, maybe they can standardize.
I'm sure if a private practitioner is taking records and following their cases, which a good practitioner should be doing, they could communicate with the universities in their area. I'm sure the people will be interested to use their cases and to compare, to give them more cases to compare with, and they can make a joining study very nicely. Both will benefit from that.
Yes, I'm sure. I'm sure about it. But thank you very much.
Thank you.
It was
Thank you for
very nice
inviting.
and natural.
Thank you for inviting.